So I'll give you our next question, which is around statins, and then if you could do a wee bit for us just around high cholesterol and statins in general. So the question we've got is, I know you've had many statin questions, which we do get quite regular ones, but what I wanted to know was each time I try a statin, my acid reflux gets so bad. Tried rosuvastatin, pravastatin, and my indigestion is so bad I can't carry on. The cholesterol number is currently 6.6 with LDL 4.7 and HDL 1.2. BP is normal, QRIS score is 13, and the patient is 70 years old. And they're just asking for a bit of general advice.
Yeah. So statins are good drugs. However, they're not perfect drugs. Okay, there isn't a perfect drug, by the way. The more potent drugs are, the more they will also have side effects. I'm gonna have to take my tie off. I know it looks very smart, but it's irritating me now. So nobody's come back and said what it is.
I don't spot it either. What is it?
My OBE tie. It's for an OBE, and I wear it when I'm going to meetings with irritating people who I feel don't really know what they're talking about, and it's to make a very silent point. I've got an OBE and you haven't, so who knows what they're talking about, right? So that's why
you don't need that with us. You don't need that with us.
No, exactly. Right. So statins are very useful drugs. The world is better because we have them than before we had them, but they are not infallible. And like with every drug, there will be winners, but there will also be losers. There are far more winners than there are losers, but there are losers. And of course, what happens in 10,000 people on average is no relevance to you, because what happens to you is what happens to you, right? So that's the background to it. And there is almost nobody, who must take statins, okay? Now, there are 3 reasons why you might take a statin, okay? The first is if you have what's called familial hypercholesterolemia, okay? And there is no doubt, we used to see these families. So these are families where you have a gene that means you make high levels of cholesterol, okay? And I remember when I was a student seeing these families before the advent of these drugs, and they would have cholesterols of 30 and 40, and people would die of heart attacks in their 20s and 30s. It was awful, okay? And statins revolutionized that because it controlled cholesterol levels, literally life-saving. Now, my comment that nobody must take statins, that's the exception. It is literally life-saving for those people. Did you know they used to do biliary drainage to treat it before they had drugs? They bring your bile duct out because, of course, bile acids are made from cholesterol. So they actually used draining the bile to get rid of cholesterol. It was a horrible situation. So in that situation, it's mandatory, right? The second group of people are what are called secondary prevention of heart disease. So heart disease, high cholesterol gets into the wall of the blood vessels. It can then rupture the vessels, causing clots to form, causing a blockage, heart attack, or a stroke, okay? And there is really good trial evidence that if you've had a heart attack or a stroke, that taking statins will reduce the risk of another heart attack, actually irrespective of whether you have a raised cholesterol. So there's more of an effect if you've got raised cholesterol, but even if you haven't got a raised cholesterol, they'll reduce your risk of a heart attack. And that's pretty clear cut, okay? That's pretty clear cut. So if you'd had a heart attack, then taking them on balance is absolutely the right thing to do, okay? There are different forms of them. You get with drugs, you get unique side effects, and then you get what are called class effects. So there are some side effects that are basically a particular drug does it, and there are some side effects that are all drugs in that type do it. Okay, so if you have a penicillin rash, that's down to that particular antibiotic, but getting antibiotic diarrhea is an antibiotic thing, if you know what I mean. So some things are general, some things are specific. So a lot of the side effects, to be honest, are to do with all statins, right? And so muscle pain and things like that, you can try alternatives and see if they're tolerated better, but they're much of a muchness, right? And then the third group of people, and that's usually pretty clear cut. Most people who have a heart attack don't want to have another one. And that's pretty clear cut. And it's the third one that's the problem, because it's much less clear cut. So the third one is what's called primary prevention. So primary prevention is to take somebody who is at risk of a heart attack for whatever reason, and to give them this drug to stop them having it. Okay, and you can calculate heart attack risk from whether you smoke, whether you've got high blood pressure, whether you've got diabetes, whether you've got family history, and doctors will put all those numbers into a computer, and the computer will give you the answer. But what can happen is that somebody who's entirely well can be told that that they would benefit from statins. The problem is the degree of benefit obviously drops through those three examples. So massive benefit from familial hypercholesterolemia, benefit for secondary prevention, but often tiny benefit for primary prevention. And balancing that against side effects is an issue, okay? And that's where you have to make an individual decision. Now, so if I got rip-roaring reflux with a statin, okay, then the first question, it's reasonable to try a different one. But for those of you who haven't had reflux, it's a pretty miserable thing if it's bad. Okay, so what's to do? So the first question is, how badly do you want to take a statin based on your cardiac risk? That is absolutely the first question. Because if it's only to reduce a marginal risk based on numbers, if you haven't had heart problems and nobody in the family's had heart problems, it simply, to me, isn't worth it, because you only get one crack at life. Okay, that's a grown-up decision. A doctor will only look at policy, and the policy will be you take it, but it's your life. If you can't sleep at night because you're getting reflux, then marginal advantages in terms of a hypothetical heart attack risk is not good enough for me, right? So I would first of all try a different one. If it's a class effect, I would then ask how badly you would do it. This, incidentally, is what we have with urso as well. So how many people are truly intolerant of urso? The answer is not that many. How many people don't take urso because they don't like taking it? It's a larger number of people. But those are people who truthfully don't need urso because their blood tests were fine anyway, or people who we just put straight onto second line therapy. So if you haven't got anything else and you need to take something, you're stuck with what's there. But actually, there are other options. And then the third option is actually a fibrate. So we talked about bezafibrate. Bezafibrate and fenofibrate have been around since the beginning of time, and they are originally cholesterol-lowering drugs. They were in widespread use before statins. They were the statins of the 70s and 80s, and the only reason they're not used for cholesterol control is because people developed statins that are better, and they are better at reducing heart disease, but they are really effective. So statins are better for reducing heart disease risk, but fibrates are still very good cholesterol-lowering drug. They don't have the general heart attack reducing effect. That's the difference. So if you've got highish cholesterol, which you have at 6.7, the LDL is a little bit high. HDL is often elevated in PBC, so it's all a bit of a complex picture. But the net result of all of that is statistically, you would probably benefit from a statin. Whether you as an individual want to do that is a different question. Unless it's secondary prevention after a heart attack, it is one where you need to make a decision. But I, in that situation, would try a fibrate, which in our experience probably causes much less in the way of reflux. So I think, like everything, it's like the old joke, giving up drinking, giving up smoking, giving up fatty food. You don't live longer, it just feels like it. And I think, the rest of your life, with horrible reflux, and the other thing, of course, is with risk. Risk is a funny beast, isn't it? Because people come along and say, I don't want to take this treatment. They come to the clinic and say, I don't want to take this treatment because of the risk. But I point out to them, they took a risk in coming to the clinic this morning because they could have had a car accident. Okay, so they took a risk. So it's paradoxical to take a risk in order to turn down treatment because of the risk. But if they'd stayed at home and sat in a chair, they could have had a pulmonary embolus because they were immobile. So there was a risk coming to the clinic. There was a risk staying at home. Risk is everywhere. It is what's acceptable risk. And that's the point. You can't de-risk everything. So you have to decide what the risks are. And, in this situation, remember that reflux can predispose to cancer in the esophagus. So you might reduce the heart disease risk, but you might introduce another risk. So it's never, so you've got to look at, and this is what's called in medicine is called equipoise, right? So equipoise, we've never talked about that before. But equipoise is where you can make an equal argument pro and against doing something. Okay, so you can, in general, and say antibiotics for bacterial meningitis. It's like that, isn't it? It's so obvious the benefit is there. You don't need to consider it. So this is in one of those. So if it's familial hypercholesterolemia, it's like that. If it's secondary prevention, it's like that. And sometimes it comes down to that. And that's where you good doctors would have a discussion with you where they would lay out both sides of the argument in a neutral way and allow you to make a decision that's right for you. And I do a lot of that in the clinic. We do it around, for instance, transplantation, the timing of transplantation. Here are the pros, here are the cons. Here is what you might think about with one, here is what, but you do it in a neutral way. You're not trying to nudge people in a particular direction because it's equipoise and there is no, what I would do is neither here nor there. Where the further out of equipoise it is, the more you will encourage people not to make daft decisions. And that, again, good doctors will help nudge you. Okay. But it is still always your decision, no matter what the doctor says. So try a different statin, try reflux treatment, of course. Think about why you're taking a statin in terms of your individual risk. And then if you really can't tolerate it and everyone thinks it's a good idea, think about a fibrate.
No, that's great. Thank you for